Thank you, Raju, and the Delhi team. Great so far, and I think we're going to have a great time today and tomorrow. Now, my question is, I think we as orthopedic surgeons, we're just thinking of knee as just as a mechanical organ to make us run around. Is it all mechanics? And why are we have got very good at doing ACL reconstructions, meniscal repairs, but still we are getting arthritis in the knee within few years, or 2 years, or 15 years, most of them. So is there something else that we need to see in these patients? Are we just simply mechanically thinking of all these? That's the first question. So this is actually a famous actor in my state who jumped off a moving bus for a movie shoot, and this happened at 5 p.m. He lands up in my hospital, does an MRI, and has a mid-substance ACL tear. He's got a latissimus root tear. He's got a medial meniscus posterior horn tear. He's got a 2-centimeter defect in the middle femur condyle. The trochlear bit, we missed it because the problem was chronic. We only found it in endoscopy. This is what you can see. There's nothing new here. I don't want to show anything on the MR. It's all there what we talked about. And that's the femoral condyle defect and the trochlear defect, the chronic defect on the left, and the femoral condyle defect on the right, and the root tears and the medial meniscal tear. Now, my first question, ARS. At this stage, he comes in at 10 o'clock at night to my hospital, does the MR. Next question, what will you do at first? What is the most important factor which determines when do you intervene surgically? Can we have the ARS questions, please? So it's the range of motion. So can I say the results? So it looks like the range of motion seems to be the most important thing here for most people. So if you have a good range of motion in day one, we are ready to operate. Is that what we are saying? Do you agree with that? The range of motion generally tells us that the knee is probably quiet and not too bad, even with such a big injury. Can I put a second?
It's always a combination of all. So if you've got a good range of movement and within limit and the swelling is down, so one factor may not be just the only factor guiding, but it could be a combination of.
So you think how comfortable the patient is, no much swelling and the range of motion. So you're not bothered about the bone bruise or multi-ligament injury, whatever. Because this is like a multiple injury knee.
No, but that option was not there. I mean, look at.
Okay, I just said okay. This.
Yeah,
okay.
Look at this.
Yeah. Know. So range of motion, fine. Can I have the next ARS question, please? So this is actually important intervention. Question. It's not important factor. What's the important intervention we do? Simple question. We just do the standard rise. Do we aspirate day one? Do we aspirate and start physio? Or do you aspirate and put steroid into the knee? So it's just rise. Great. Can you go to the, so essentially that's all of us do, I think. We just rest eyes and start get range of movement physio and then start once the patient is comfortable. Can I go to
Dr.
the next
Jacob,
slide?
here, I just want to ask one thing, like patient coming to emergency with knee trauma, X-ray is normal. Obviously there is no bony injury and we suspect some ligamentous injury in the knee. Are we getting MRIs done the same evening or the same night? Or initially we used to think that edema should settle down and we should wait for 2 to 3 weeks before getting an MRI done?
I think there is no role for waiting at all. I mean, if you clinically suspect that the patient
we are getting the MRI done the same evening.
There's no waiting. You're not getting any additional information for waiting on the bone bruise or whatever. The edema is not going to change our MRI. So you can do an MRI day one. You can know what's up. There's no point waiting as far as I understand. So clinically, if you suspect, you can straight do an MR.
Yeah, so I think, of all these options, Jacob, that you have here, aspiration becomes important if clinically you see that the patient has got AMI. So if he's got arthrogenic muscle inhibition, AMI, then I think you should aspirate. Otherwise, his quads will not activate. And now we have a lot of data which shows that AMI is one of the important causes why you may land up with a knee which is not settling after an acute injury. So I think that's an important aspect to consider.
Will the MRI, if you see a major bone bruise, which you used to do, will you change your...
Time and again, we know that bone bruises, yes, they will tell you what structures may be involved, but the severity of the bone bruise in an acutely injured ACL injured knee or a multi-ligament injured knee will not have much correlation, or the presence of duration of bone bruise will not have much correlation with respect to your timing of surgery.
So this patient actually, he comes to hospital at 10, has his MRI, goes home. I see the MRI at home. I told him this is what it is. If your knee is cool, you can move it easily. I can move it quite well. I don't have much pain. I'm ready to get operated. So he comes at 8 a.m. I examined him first time. They're quite cool. He's moving his knee fully, and he wants to get back to work quickly because he's in between two big movie shoots. About 100 crores are blocked. So I said, as far as knee is mobile, I can operate. So I went on day one. So it happened at 10 p.m. night. I went at 8 a.m. next day. Will you agree with that? Yeah. Can we go to the next slide? Sorry. Yeah. So this is what we did. We did the first stage, one stage ACL. We did the root repair, medial posterior horn. We did autocart for the medial femoral condyle. Trochlear, the patient's wife is watching the surgery downstairs. Trochlear lesion was a chronic lesion. I was not sure what I'm going to do. I thought, anyway, he's never had any complaints as far as the knee is concerned. He does a lot of weightlifting. So the trochlear, I said, anyways, he's going to be off for 3 months. Might as well I do the autocart for the trochlear to have not crossed any borders there. So even if I need to do ACL late, I can do it. And we started CPM. We put them on doxycycline. Anytime I do a cartilage work, I do a doxycycline. And we started BFR. Sorry.
I mean, I just wanted the opinion of the panel. I mean, we have all very quickly agreed on a acute ACL reconstruction, but is that the usual practice? I mean,
No.
what are,
No, it is not.
So why, I mean, what combination of factors makes you...
The factor which he mentioned was the demand and the requirement of the patient and the type of...
Everybody will want a surgery on day one.
Usually they don't. They run away when you talk about surgery, isn't it?
Limp away.
Yeah. So most of us would actually delay it, but his situation was completely different what he's talking
But
about.
I would do it even in any other patient, provided the knee is cool and he can move it easily. Because to me, waiting 6 weeks and 3 months and all those things, I would do
So
stays
if it
and
is
things.
moving freely and it
Without
is-
pain
it is,
and-
yeah,
and
without
quite
pain,
comfortable.
that is the indication. But most of them actually
So some
don't do
people
that
pay-
in first day.
Okay.
That's what the problem. The thing we face is most of them don't do that on the first day, and that's why we wait. So we wait 2 weeks, 3 weeks. That is the reason we wait. And if he's doing it on the first day, there's nothing wrong.
I think if you have a good physio team and you can start it early, I think it's critical even in multi-ligament settings. It's not really about what you do. Of course, you need good range of motion. It makes your life easier when you start. But acute ACL repairs are done on day 1, day 2, day 3. I think if you have a good physio support at the back of it, I think
That's the
that
most
seals the
important
deal.
thing.
That's
This
it.
thing of waiting till that if you do acute ACL, you're going to get a stiff knee is wrong. You've got good physio, and if you got the knee is cool, you probably can get away. But there's some other data against it. Anything
So
else?
we
sir?
need
Jacob,
to just
get
treat
them
the
going
MRI,
quickly.
sir, or his complaints are instability or not? So just don't bother about complaint nowadays.
I mean, this case was he couldn't.
No, the
yeah.
one who are doing repair also, it's a day 1 we see that ACL is torn. So there is no complaint of instability because it's day 1.
I would, even a young patient, active patient, I would offer him surgery. I don't know what rest of the parents is. For me, no.
So the
Unless
question
it's
is there any role of conservative management? Because if you're offering surgery on day 1, that means you are not giving him the chance of healing or is there any role of conservative management?
With this patient,
Not
No.
this patient, any patient.
In general.
Not this patient.
No, regarding this
That depends on the
patient,
profile of the patient. If the patient
Regarding
is
this
young and
patient-
active and wants to be active, then we would offer a ACL reconstruction.
Demand of the patient.
I mean, if the patient is a 35-year-old female, a housewife, sedentary, acute ACL, 6 hours into the injury, are we going to
That's
operate
what I'm
on her or
asking.
not?
The role of
Question,
conservative
we'll have to ask-
management of ACL.
I don't think there's anything conservative in a 35 too. If it's sedentary, someone who's close to 50s, maybe I would consider doing that in the OA because we don't change OA as far as ACL is concerned. We know that we may not change arthritis. That's what I'm going to come to next. Does anyone use doxycycline when you do any of this work?
Dr. Kanchan?
yeah. So Jacob, you're saying a patient comes to you within 24 hours, he has a full range of motion. I cannot understand what's the seriousness
This
of his
guy-
injury, even if the MRI says this.
Yeah, but this guy could do it easily. I told him the night, he's a well-read guy. I said, if you can do it, I'll see you in the morning and operate. And that's what he was. Ice packs, he was...
Can we
he
go
did
back
ice
to the
packs.
MRI images again, please?
I'm sorry, is blood flow restriction therapy, which again is controversial, which only increases, sorry.